decal only has treatment for hypertension, so it doesn't matter. But the number is the same.
Calculated only applies to individual sports.
Yeah, so on the app that we were told to get, my answer is 29.4, but we didn't have to say if they were treated for diabetes. So I just don't know if that affects it greatly or not.
You got the same percent?
Yeah, 29.4%.
Yeah. About 60 to 70% of people with diabetes have hypertension. So, and it increases risk for coronary event. So, which one do you use?
MD Calc and then the ASCVD risk calculator. And also didn't need his diastolic blood pressure.
Yeah, I don't know what their background. I don't know what their back end looks like. I don't know what they're basing it on. But it sounds like you got similar. Does it give you recommendations on the other things?
It says high intensity statin recommended. And
Does it tell you about aspirin?
there's a lot of stuff in here I haven't read before, so
Okay.
probably.
Okay, good.
I was taught as far as smokeless tobacco, like 1 can of dip was equivalent to 3 packs of cigarettes. And I just Googled it and it said the nicotine content of 1 can of dip or snuff is approximately 144 milligrams of nicotine, equaling 80 cigarettes, which is 4 packs.
Okay, so if we're looking at, now we're looking at chronic stable angina. So the definition is angina that's been stable for at least 3 months. Chest pain usually lasts less than 20 minutes, relieved by rest or use of a sublingual nitroglycerin. Predictable, meaning if you go out and shovel snow, you get chest pain. Or you're bringing in groceries, you get chest pain. That's what they mean by predictable. Plaque generally consists of small lipid-laden core surrounded by a thick fibrous cap. So is that a high-risk plaque? No, because it's thick and it's intact. So a thin cap would be a vulnerable plaque. So what they're saying is that it's a stable plaque.
Where would you get that information from?
Not unless they've had coronary angiography.
Okay.
Angina is predictable and reproducible, usually positive stress test if you did it in your facility. And we'll come back and do Prince medal here in the okay. So goals of therapy, we want to do symptom relief. We want to prevent them from having other chest pain. We want to improve quality of life so that they can do what they want to do. Minimize adverse effects from treatment, prevent serious morbidity and mortality. Treatment. So it's risk reduction to slow progression, so smoking cessation, blood pressure, lipid management. They're diabetic, good glycemic control, as active as they can be, managing weight, and then other health preventative interventions like influenza. Okay. So it's more than just controlling their chest pain, it's working on reducing cardiovascular risk. That's important. So our medication that we're going to use, we've got beta blockers and nitrates for the most part. We can use calcium channel blockers as well. Our goal is to reduce resting oxygen consumption. And all of these drugs can do it to an extent. So the patient can undergo a revascularization process, that procedure, that will do it, may do it. Or they can be managed medically with medicines to achieve the same goal. Okay, so for drug therapy, we're going to start with antiplatelets. So here it's aspirin is our drug of choice. Okay? Again, here it doesn't matter if they can do chewable, they can do, if it upsets their stomach, they can use enteric-coated. So that's different from what we talked about with an acute coronary syndrome where you need to use the chewable and get it in as fast as possible. So aspirin, the reason we use it, it decreases the incidence of an MI. Okay, that's important. Why are we doing this? In sudden cardiac death. The dose range is a little bit broad, so 75 up to 325. Most people are going to use the baby aspirin. At those low levels or low milligrams of 80 milligrams per day, you knock out the Cox-1 in the platelet. So if we knock out Cox-1 in the platelet, what are we mostly targeting? What do we want to do? We want to make sure it can't produce what? Thromboxane A2. Okay? So that's what our major goal is with the aspirin. What if they can't take aspirin? They're either allergic, maybe they have asthma and it worsens symptoms, so they can use Plavix. You'll notice all the other ones are not listed there. So this is the recommendation. So it's considered second line. We would not use it first. So what is the unusual thing about Plavix that we have to keep in mind? To begin with,
Neutropenia.
it's a prodrug, right? So what does that mean? Okay, so it has to undergo some type of transformation. How many steps does it take to get it to active 2? So that's where the resistance comes in. So avoiding, what's the big drug interaction we're going to avoid? Giving it with a proton pump inhibitor, because that will decrease its absorption and transformation. Dual platelet. So do we use dual platelet in stable angina? Usually not, unless they've had a stent or they've had a recent acute coronary syndrome. People who've had acute coronary syndrome, how long do we treat them with a dual platelet? 12 months. All right. So normally we don't do dual platelet. That is for acute coronary syndrome. If they have a stent or stents placed, there's a protocol of how long that they are, and they'll be on dual platelet. And they'll be on anticoagulants as well for a while. Okay. So those folks, they already have angina, their secondary prevention, they're going to be on an aspirin. Acute treatment, I pulled back in this, if you use these to study. Remember, platelets only have Cox-1. And then aspirin, it acetylates that platelet cyclooxygenase enzyme. And how long does it render that platelet ineffective? 7 days, the life of the platelet. Once you acetylate that enzyme, it can no longer aggregate. Okay. All right. Nitrates. So this is looking at acutely. We use them acutely and chronically. So acutely, they are used to treat the symptoms of angina. And we can use them to treat or we can use them to prevent. So you can teach your patients, if every time you bring in the groceries, you have chest pain, then take a sublingual nitroglycerin or nitroglycerine spray before you do that activity. Usually 15 to 20 minutes, if they've got that long. Okay. Or you go outside and when you feed the cattle and you're lifting up that hay and it causes chest pain, take it before you do it. Okay. Or we can treat when the symptoms come up. So remember, the nitrates are primarily venodilators. Okay, so capacitance vessels for the most part. Only at the higher end do we see arterial effect. The biggest thing is we reduce myocardial oxygen demand. If you go on the next page, we'll go through some of that, just to remind. So remember, if we dilate veins and we increase the capacitance, what do we do to preload? We decrease preload. Okay. So what does that do to the amount of work on the heart? It decreases it. So what happens to myocardial oxygen demand? Decreases. So those are all the good things that you get with nitrates. To some extent, they will reduce afterload, but not to the same extent that you get preload. So you can get afterload reduction. People can become, they can't get hypotensive, so that's one of the problems with nitrates. This is just to show you wall thickness, or wall stress. So wall stress, the determinants are the pressure on the muscle, the radius of the chamber, and wall thickness. So if you can reduce pressure, what happens to wall stress? It goes down. Okay. So I like keeping these in my head because it reminds me, or I can quickly go, yep, if I do this, this is what will happen. So we want to reduce wall stress, reduces oxygen consumption. That is what all of our therapy towards angina is after. The beta blockers and the nitrates, all of them are going after reducing the oxygen demand. Let's talk about the products and what you need to teach your patients about it. On page 11, so when we give, for acute treatment, we're always going to use a sublingual route. You have three choices. You have tablets, sublingual tablets, you have a spray, and you have a powder. They're all should be delivered under the tongue. The spray can be sprayed into the mouth, but you probably will get a little bit faster also if you'll spray it under the tongue. And why do we give stuff sublingual? Faster because it bypasses first pass in the liver. Very good. Okay. The one thing I always ask patients, since we were diabetes and I saw a lot of people with heart disease, I always ask them, do you carry nitroglycerine with you? A lot of them did not. So I always ask, and I always use it as, how many nitroglycerin have you used since I last saw you? I think it gives you some indication of their use, their frequency. It also tells you whether or not the drug is still active, which we'll talk about here in a minute. So I would make sure people have prescriptions that so they can carry sublingual nitroglycerin. Just kind of going down the list there, you see these are the tablets. Oh, you can't see that. So those are tablets, are really tiny, small, and there's their placement under the tongue. We don't chew them, we don't crush them, we don't swallow them. They just need to go under the tongue. They will dissolve pretty quickly. The spray came about because it's even faster. And I'm not sure what the advantage of the powder is. It's out there, it's a different form, if people like it. Probably goes to also, it's more stable and and some people may prefer it than the tablet. Okay, recommended strength. The 0.4 is the most commonly one used, 0.4 milligrams. If you have people who don't respond to that, you could go up to the higher dose. If you have people who have too many headaches and can't tolerate the 0.4, you can go down to the 0.3. I always tell patients, sit down when you take it. One is because cessation of activity will help decrease the chest pain, but also is that in case they get hypotensive, they don't fall, particularly if they're by themselves. Also, telling them how often can they take the tablet? Every 5 minutes they can take a tablet for a number, for how many? 3. Okay. So in the past we've said do that, and if that doesn't work, call 911. Well, probably is better is that if they do not get their usual relief from that first tablet, they need to put in a call to 911 then. Otherwise you've waited 15 minutes if you go, or 10 minutes if you go through all 3 tablets. People should get relief pretty quickly. 3 to 5 minutes, if it's a usual, they should see quick relief. And you see duration of action there is pretty short, 15 to 20, 30 minutes. Tolerance does not occur with sublingual nitrates, and we'll talk about that because with the chronic nitrates, orally, we get tolerance. Here's some counseling points. Keep the nitroglycerin in the original container. It's a very volatile substance.
Yeah.
Yes, this one will not blow up, but it comes out of that tablet very easily. So whenever you see something in a brown bottle, it tells you that it is light sensitive. We don't put stuff in brown bottles because we think it's pretty color as pharmacists. We put it in there because they're light sensitive. They're also humidity sensitive. So these tablets will crumble easily. My recommendation to patients is once you've opened it, after 6 months, toss it. I've seen other recommendations up to a year. This is why I like this packaging. So usually we give them a bottle of 100. This packs it in 4 small bottles of 25. Or the other thing I'll do is if they've used these before is like keep the small bottle, you can leave the other one at home and just fill it. Okay. The more times that bottle is open, the more nitroglycerin you lose. Okay. So if people are open, if they're getting in and they're using them a lot, the product will degrade faster. The other thing I advise patients to do is when you get your prescription, take the seal off and take the cotton plug out of there. For a couple of reasons. One is that I think when you're having chest pain, you shouldn't have to dig all that stuff out. That's one. The other is that cotton becomes a reservoir for the nitroglycerin. So if you take it out, then whatever nitroglycerin has been aerosolized will stay kind of in an equilibrium with the tablet. I always have patients I want to see your nitroglycerin because I want to see where they put it. If they put it in their pocket, if they put it in a tissue and they've got it in their pocket, or they have put it into another device or holder, I usually move them on to a new bottle. The way, and a tried and true way of telling if the nitroglycerin is still active or there's still active drug in the tablet is when they put it under their tongue, it will gives them like a tingling or a slight burning sensation. Okay. Usually that means there's still drug in the tablet. So if they've been carrying it around a long time and they're not getting benefit, that is one of the things I consider is that the drug's just lost it's been too volatile and they're no longer active, enough active ingredient in the tablet to give them relief. Questions about the sublingual? I always use those prompts as ways to figure out what are they doing. And sometimes it will lead you down paths you didn't expect. Okay, nitroglycerin spray. So this is another delivery method. It's in a spray. It's stable longer, so 2 to 3 years as opposed to 6 months. For people who don't use it very often, it might be an option. Or for those who use it a lot. It comes in different strengths. The 400 microgram per spray is the most common one used. In terms of the couple of things to keep in mind, it has to be primed. So when they first get it, there's a little leaflet that comes with it, and if they will, if you'll go over that or read, and encourage them to keep it and read it, it tells them to like spray it 5 times. So what that does is it fills up the space that's in between where the drug is and the mouthpiece. If they don't use it very long and it sits around a while, we tell them prime it again. If you get into trouble and you need it, is to prime it once or twice. Don't shake it. We'll talk about this with other drugs. If you shake it, you put bubbles into it, and the bubbles can actually occlude, and you can't get the drug out of the device. So the advantage is it doesn't need to dissolve and it's stable for longer. I didn't price it. Kristen's gone. So.
Oh, right here.
Oh, there you are. Sorry. Do you know the price?
I've never seen the mix. We always use tablets at my pharmacy.
Really?
And it wasn't, most insurances cover it fully. So,
Fully?
Yeah.
Cover it fully. Okay.
They might have like a small, less than $10 copay, but most people it's fully
Okay.
covered.
All right, I agree. Most of the patients I saw like the tablets, and I don't know why. Here they use a more, you use a very close to the mouth spray, and they tell the patient don't drink anything for like 5 to 10 minutes afterwards. Don't breathe it out. Don't swallow it. Try to leave it in your mouth as much as possible. The sublingual powder, go nitro. It comes in little boxes of 36, so it's just like a little thing of sweetener. So they tear off the packet top, they tap it down, tip it over, and put it under their tongue.
Is this a one-time use or is this 3 doses as well?
Pardon me?
Is this do you still do the 3 doses every 5 minutes?
Yeah,
For
yes,
the
yes.
powder?
Because these are 400 micrograms also. It's just 3 different ways to get the drug, different forms of the drug.
Dr. Letassy, the other thing was that we dispensed a lot of 25 count. We hardly ever did a 100 count.
You could
And
break
for
up
30
that
days.
4 25s and dispense one.
Yeah, and we would put it in like the easy off lid, so if they were having an attack, they're not trying to
Yeah.
struggle with the.
I mean, that's reasonable. If they don't use it very often,
Yeah.
that would be very reasonable. Okay, adverse effects. It's a vasodilator, so these should start to make sense. Headaches, number 1. I told you, it's like blowing the top of my head off. They can be really impressive. They can, their blood pressure can drop, so they could get lightheaded. Sometimes it makes them sick. Sometimes it'll cause their heart to race. So why the tachycardia? Where is that coming from? Okay, you got vasodilation where that causes what? Preload, afterload? Preload goes down, okay? So what happens to cardiac output? It decreases. So in terms of how the body will compensate, what can it do? Right. Heart rate goes up. This is true for almost every peripheral vasodilator. For the dihydropyridine calcium channel blockers, it's the same thing. Anything that peripherally vasodilates usually will cause an increase in heart rate. So reflexive to keep cardiac output up. Okay. Questions about those? Big contraindication. Current use with phosphodiesterase inhibitors. You can cause life-threatening arrhythmias, blood pressure, sorry. So if you go back to this one and look, I think it's my son telling me he's done with his EOR for family medicine. So see, right here, so you increase that in GMP, so they can get severely hypotensive. Can be fatal, so be sure you ask about those. Okay, moving on to page 13. Any question about the nitrates? That's acute. So separate them out in terms of how you use them, or what you do for acute, what you do for chronic. Okay, chronic treatment. So these are people who are having frequent symptoms. And you're going to move them from just treating them with aspirin and sublingual nitroglycerin to more oral, or to an oral regimen. So the drugs of choice are beta blockers. And why is that? Well, in that first line, survival benefits increase in people who are on beta blockers. Calcium channel blockers cannot claim that. Their major effect is decreasing myocardial oxygen demand. And you should be very familiar with the way they do that. So they decrease heart rate, right? And we call that what? Negative chronotrope. They decrease conduction through the AV node, that is dromotropic effect. Contractility, so they're a negative inotrope. Okay. And decreased wall stress. So their benefits over the other two drugs we use: reduced episodes of silent MI. Silent ischemia means they have no pain. So ischemia is taking place, but the patient doesn't perceive it. Not uncommon in people with diabetes. Reduces early morning peak of ischemic activity. So catecholamines rise in the morning. A lot of heart attacks occur early in the morning. So some of that's due to that rise. So beta blockers can prevent that and reduce mortality. Improves symptoms 80% of the time, so they're very effective. Now, exercise tolerance, I want to draw your attention to that so that when you go back, it doesn't bring confusion. So improved exercise duration, meaning they don't get chest pain, they can keep doing the work. But what was one of the side effects I told you about beta blockers in terms of exercise tolerance? It goes down. Why does it go down? Why might they complain to you? I'm tired, I just can't do what I want. Heart rate, they can't raise their heart rate in response to a workload or a demand, increase in workload demand. Okay. So these are kind of two different ways they're looking at it. They can do more of what they want because they don't get symptomatic. However, on the other end, they may complain about fatigue because they can't mount a heart rate response. Only anti-anginals proven to prevent reinfarction. We talk about, well, we've already done MIs, but that is one of their big reasons. We talked about in acute coronary syndrome, patients coming in either with non-STEMIs or STEMIs, we talked about a group of drugs that we start right at the beginning within the first 24 hours. What were they? Well, aspirin we're treating the symptom, but what other things are we going to start them on in the first 24 hours? ACE inhibitors, beta blockers, statins. Go back and look at that handout. At the very beginning, we start with, within the first 24 hours, we're going to put these people on this. Now, it isn't going to do anything immediately for their acute coronary syndrome, except maybe the beta blockers. But we're going to, so this is one of the drugs we're going to start. Contraindications. These ought to start now to be very familiar. It's a negative dromotropic effect, so it can worsen second and third degree AV block. Beta blockers almost always will cause a primary AV block. So what interval usually is prolonged in people who are on beta blockers? The BR interval. Bradycardia. So if they're already bradycardic, we're just going to make it worse. Sick sinus syndrome, make that worse. Decompensated heart failure. We can use beta blockers in heart failure. We'll talk about that, but you got to get them stable first. You got to get fluid off, and then we can start them. I put in a note in there about the heart failure with reduced ejection fraction. Beta blockers do prolong, and we'll talk about this in heart failure, do prolong survival in patients with heart failure. But the first thing is get their volume overload status corrected. The reason for that, we talked about the last time I met with you. So when you use beta blockers chronically, what happens to the beta receptor population? It goes up. They upregulate. Okay? So in patients with heart failure, usually they have a high sympathetic drive. And so what happens to their beta receptor population? Goes down. Chronic stimulation, usually of an agonist, will cause a downregulation of receptors. So one of the things that beta blockers do is they upregulate. You've got more receptors to deal with, and you decrease that sensitivity of the heart to circulating catecholamines. We'll talk more about it, but I want to put it in there because we kind of woven heart failure in there a couple of times. Guidelines for use, you need to know these. Our target resting heart rate, so resting is 50 to 60. When you bring them in, take their pulse. Some people will get them up and walk them and see how much they can raise their heart rate. Some people use a guideline about 10% above is acceptable. Higher than that, they may alter it. Initial dose, we start low and we titrate to response. We talked about it not abruptly withdrawing, right? And why was that? We've upregulated all those receptors, so now they can react to all that circulating catecholamine. So we're going to taper over a few weeks. There isn't any set schedule. So we're going to look at the person, consider what their underlying heart disease is, their likelihood for relapse, and titrate them all. We can use beta blockers with a calcium channel blocker. We can use it with nitrates. Beta blocker selection, we prefer the cardioselective, which means what? Selective for beta-1 receptors. Okay. Usually that occurs at lower doses. A lot of those drugs you lose their specificity at higher doses. The cardioselective ones are at the bottom. So you have atenolol, metoprolol succinate, metoprolol tartrate. Remember I told you this is where salt counts. The tartrate is always the immediate release and the succinate is the extended release. There are beta blockers that have intrinsic sympathomimetic activity. You have to be careful in using those in somebody with angina because they can worsen it, especially if they have severe disease. As long as you're getting more lowering of myocardial oxygen demand than you are raising the heart rate, usually you could use them. Most people don't because these others are widely available, they're cheap, and they work. Adverse effects, you should know these pretty well by now. The fatigue, we talked about, the heart rate, bradycardia, hypotension, acute heart failure, precipitating those, bronchoconstriction, erectile dysfunction, and CNS effects. These CNS effects tend to be more with the lipid soluble beta blockers. So propranolol is one of those. And so what happens is those tend to move into the brain very easily. Patients may complain of nightmares, hallucinations. And then they'll describe them as very intense, very like in color, frightening. So those are the types of nightmares that they will have. You can switch them then to a one that is water soluble. Okay, questions about the beta blockers? Number one, calcium channel blockers. So you learned that there's two different types, right? Dihydropyridine and non-dihydropyridine. You need to recognize which are which. So the dihydropyridines, there's a lot of them. They are predominantly vasodilators. They predominantly work in the periphery. Nifedipine is one of the oldest ones in that group. Amlodipine is the most commonly used one. We tend to like to use extended release. We don't use the short-acting as often because they tend to worsen other problems. They can drive up heart rate and precipitate a cardiovascular event. Major ADRs. These are related to their vasodilation. You commonly will have to use them with a beta blocker because they will raise blood pressure. You commonly have to use them with a diuretic because all vasodilators will cause a fluid retention. All of them. Did you talk about how the mechanism for that? For time's sake, I'll talk to you about it in heart failure, about why those vasodilators are causing fluid retention. Think about the effect of decreasing afterload and how the kidney is going to respond. So calcium channel blockers decrease myocardial oxygen demand. They do it a little bit differently than the beta blockers do. They do it through coronary and peripheral vasodilation. So overall effect is they're coronary vasodilators. They decrease myocardial contractility. That would be more diltiazem and verapamil. So the non-dihydropyridines are better at that. They improve coronary blood flow and inhibit coronary artery vasospasm. Easy to remember because we use it for Prince metal. Variant angina. So who's a good candidate for a beta blocker? Well, a calcium channel blocker. If they can't use a beta blocker, then this is your next drug. If they have underlying rhythm disturbances, then you really have to think about verapamil and diltiazem because they work much more on the heart. The other ones work much more in the periphery. So verapamil is a very strong AV node blocker and contractility, decreasing contractility, negative inotrope. Diltiazem is a little bit more balanced. Prince metal, angina, calcium channel blocker. Peripheral vascular disease. Patients will do better than they will on a beta blocker. Severe ventricular dysfunction, again, avoid the verapamil and diltiazem. Amlodipine would be preferred. Okay, calcium channel blocker selection. Talks about using the long-acting. If you're going to use a dihydropyridine, use the long-acting. Amlodipine is common go-to. Fairly well tolerated. One of the bigger common side effects with amlodipine is fluid retention. Patients will usually come in and they'll tell you, my calves are swollen. So then you're, depending on what the patient's cardiovascular problems are underlying, you're going to figure out, is this disease progression or is this drug effect? So keep that in mind with amlodipine. It will with all of them, it's just you'll probably see it more often. Don't use the short actings. They increase heart rate and they increase MVO2. The non-dihydropyridines, remember which ones are negative inotropes and chronotropes. Adverse effects. Verapamil is awful on constipation for causing it. So, several older people coming in with big impactions on verapamil. Peripheral edema, mainly the dihydropyridines. Peripheral vasodilators, think fluid accumulation or retention. Hypotension, like any drug that's going to affect blood pressure. Bradycardia, the non-dihydropyridine. They work on the heart. The other class will raise heart rate. Questions about those? Okay, let's go to nitrates. Now these are the long-acting. You're going to add these to a beta blocker or a calcium channel blocker. You're not going to use them alone because their ability to raise, they're not as good, and they don't have the data behind them in terms of survival rate. But they're very good for symptom control. But the patient will do better if you've got a beta blocker or a calcium channel blocker on. So it also is that the body builds up a tolerance to nitrates. So this is a kind of an unusual part of this drug. We don't give it 24/7. We always allow at least an 8-hour nitrate-free period, regardless, except for sublingual. If we use a patch, we use a capsule, or we use a ointment. Okay? So that's important to remember. So if you're going to prescribe them, you can use an extended release, which is once a day, or you'll see down that there are immediate release under isosorbide mononitrate and isosorbide dinitrate. So when we prescribe those, I ask the patient, what, are you up by 8 o'clock? When do you get up and when do you go to bed? So if they're getting up early, and so 8 o'clock, 2 o'clock in the afternoon, that is a good time to schedule those, as long as they get that 8-hour. The reason is that you deplete the nitric oxide, like in that, so you just can't produce the effect anymore. So you have to take it off, let the cells regenerate that, and then the drugs will be effective again. Transdermal route, we put it on for 12 hours and we take it off. So put it on in the morning before you go to bed, take it off. Side effects are just like what we saw with the sublingual. So the hypotension, the headaches, If they're wearing a patch, they might have skin irritation, would be the only difference. Next page. Those phosphodiesterase inhibitors, always ask. There is one other drug, I have never seen it used, but it is available. It's quite expensive, but it's Renexa. Kristen, you ever seen this? Really?
Yeah.
How much does it cost, do you know?
It was super expensive, and we had like 2 people on it.
Okay.
Who had really good insurance.
So Ranolazine, Renexa is an anti-anginal, works very different from the beta blockers, or the calcium channel blockers or the nitrates. Actually works on sodium channels. It's more like your class 1 antiarrhythmics, but it is not used as an antiarrhythmic. It's second line. You would only use it if patients cannot tolerate your first line drugs, or they're not responding, and maybe they're not a candidate for an invasive procedure. So look under contraindications, pre-existing QT interval prolongation. Remember, with most of the class 1, that's what happens. You affect phase 0 with sodium, and their QT interval tends to go out, except for the 1Bs. Drug interactions are a problem. We don't see that with the other drugs, so you have to keep in mind that the 3A4 inhibitors can increase the concentration of this drug. Just want you to know it's out there, so if you see people on it, I would doubt, unless you're in a cardiology group, that you would use it. I've never seen anybody on it. But it's there. Okay, Prince metal. Last page. So this is a vasospastic pain. It is not due to atherosclerosis. So usually you'll see it in younger people. And they don't have, they may have changes in the EKG when they're having an event, but it will go back to normal. They usually don't have risk factors. So those are kind of the keys with them. You can give them sublingual nitroglycerin to carry, but their chronic management is calcium channel blockers, and they are pretty effective in preventing. You could combine them with a long-acting nitrate if you can't get full, or they can't tolerate the full dose of the calcium channel blocker. We don't use beta blockers. It makes it worse. They're not effective. Don't use aspirin. So keep in mind, it's not atherosclerosis. Okay, so questions about that? Comments? Okay, let's look at drugs that should be avoided. So the Cox-2 inhibitors, why would we not use Cox-2 inhibitors in these patients? So what's left unopposed? Cox-1. What does Cox-1 do? It increases thromboxane. Okay? So we're not going to use Cox-2. Now, you see down there the non-selective non-steroidals. So they will affect both Cox-1 and Cox-2. So there's been a lot of information in the literature about, do they worsen heart disease or not? And probably in some people they do. And why they do, it's probably got to do with the balance of that drug in that person related to Cox-1 and Cox-2. So you can see people who overuse or use a lot of let's say an ibuprofen, that they can have a heart attack because of the use of that drug. Now, they've got underlying disease, but it can precipitate. So be careful. Caution your patients to be careful. Probably use here and there is not going to hurt, but it's prolonged use. So let's say they've got osteoarthritis and they're using it every day, or they can go out and buy it. They don't have to have you to tell them to do it or not do it, but I would have that discussion with them about use Tylenol when you can. Let's use other methods or interventions for pain control if needed. Sympathomimetics. So this would be like your cough syrups, your nasal decongestants. So again, these are things people can go and get over the counter. So they can raise Because they're sympathomimetics, they can raise myocardial oxygen demand. It's really common in the winter when I would see people and their blood pressure was way up. First thing I asked them is like, what are you using? Are you using an inhaler or an oral decongestant? Those will tend to raise blood pressure quite a bit for the course of the time that they're on it. Cocaine, duh. Okay, we don't want you to use it. It's a very powerful vasoconstrictor. There are protocols written up just for MI-induced cocaine, like cocaine. So in like the population at the family medicine, lots of cocaine, lots of crack use. So asking about illicit or recreational drug use is important. The last, estrogens tend to be thrombogenic. They increase the clotting factors that the liver makes. Most commonly the 2, 7, 9, and 10, which are the warfarin clotting factors. Vitamin K dependent, I should say. So it seems to make more of a difference in postmenopausal women when you use it. Usually it's not so much a problem if you start women early in menopause on those estrogen supplements, but waiting years to do it seems to increase the risk of heart disease. So its timing is important. Okay, y'all did well. Did this help in a review? Did a lot of things sound familiar? Okay, good. Good luck. I wish you well. Send me questions if you have them.
Yeah,